Hello, my name is Tay Claidonis, and I'm here to review the weight-bearing lunge test with regards to the ankle and foot. So, looking forward during the course of this presentation, I'll first go over the purpose of the weight-bearing lunge test, discuss what the present research has to say about this test, as well as the alternative methods, and I'll mainly do this by going over some of the statistics like the intra and inter-rater reliability, as well as the validity. I'll then sum up this research by giving a quick conclusion, show a video of how to administer the test, and then some time in class will be allowed for a demo and then time for you to practice. The purpose of the weight-bearing lunge test is to measure dorsiflexion range of motion of the ankle. Some of the benefits of this test are that it's done in the weight-bearing position. Reduced dorsiflexion is commonly seen among patients with ankle injuries, and it's vital for them to get this adequate range of motion of the tibia anteriorly gliding over the talar dome, as it's needed for functional activities like walking, running, stair climbing, and squatting. Reductions in dorsiflexions prevent the pterygocoral joint from achieving its closed pack position, which leaves it more vulnerable to inversion and internal rotation forces, which leaves it at risk for repeated injury. Other benefits include the cost. It's very cheap because the only thing you need are a tape measure, tape, and a wall. Time efficient, and this test can be given out in less than a minute. It's deemed valid and reliable, and the only downfall is that it cannot be performed on patients with weight-bearing restrictions, as it is contraindicated. So now diving into the relevant research, dorsiflexion is usually measured in three different techniques: visual estimation, non-weight-bearing goniometric measurements, and weight-bearing measurements. Visual estimation has shown to give poor measurement qualities and is not recommended for clinical use. Non-weight-bearing goniometric measurements, seen very commonly in the clinic, as it should be because it yielded high reliability rates. The first of which being intra-rater reliability, which measures the consistency of one rater, and then inter-rater reliability measures the agreement of values obtained from the test across multiple raters. And these reliability rates are given as ICC values, or inter-class correlation coefficients. And that basically just measures the ratio of variance between results obtained on different occasions for a single subject. And these are expressed as values between 0 and 1, 0 meaning no reliability and 1 being a perfect reliability. And generally these numbers are accepted at 0.5 or higher. So as you can see, the non-weight-bearing goniometric measurements all yielded high numbers, as well as the weight-bearing measurements, as the ICC values were all 0.9 or higher. And then the standard of error measurement was 4.0 to 5.7 millimeters squared. This estimates how much a repeated measurement would vary time after time. So 4 millimeters, very small, meaning that it's very reliable. So moving forward into more statistics, looking at the construct validity. So this basically describes how well a measurement measures what it was originally intended for. In Chisholm's study in 2012, he wanted to see how well the lunge test measurements were related to the scores recorded by clinically relevant scales regarding function. So he used the lower extremity functional scale and the global foot and ankle scale. And to measure this relationship, he used a Pearson product moment correlation coefficient, or an R value, to assess this relationship at the initial assessment and then 4 to 8 weeks during rehab. And this correlation yields an R value, which describes the relationship from -1 to 1. -1 meaning a negative correlation. The closer the R value is to 0, that means that there's no correlation, and then closer to 1, the more positive the correlation is. And he found that the lunge test and the LEFS yielded an R value of 0.57 to 0.63, meaning there was a strong correlation. So the higher the lunge test score, or the more the dorsiflexion the subject obtained, the higher the score on the LEFS the subject reported. So when the lunge test measurement increased, so did the subject's ability to perform activities of daily living. And previous studies have shown that the non-weight-bearing dorsiflexion measurements, when related to the LEFS, only showed a correlation of 0.36. So the lunge test showed a more accurate depiction of the subject's functional ability. And then when he compared the lunge test to the GFAS, the R value was between 0.39 to 0.59. Not as high, but still deemed a moderate to strong correlation. So to bring it all home with the conclusion here, studies suggest that the weight-bearing lunge test is a valid and reliable method of measuring dorsiflexion range of motion that coincides with clinically relevant scales measuring function. In preparation for administering the weight-bearing lunge test, you need to put a piece of tape on the wall that's perpendicular to the floor and tape a tape measure on the ground that's perpendicular to the wall, and have the patient remove their socks and shoes. Instruct the patient to approach the tape measure and the wall. Have them place their hands on the wall for balance and place their foot that's being tested. So in this case, it's the patient's right foot on top of the tape measure. The therapist lines up the foot using the great toe and the middle of the calcaneus as reference points. Hold the heel down and have the patient slowly and controlled lunge forward until the knee touches the wall and then back up. The therapist is looking for the heel to rise when the patient approaches the wall. Move back 1 centimeter after each successful lunge until the heel rises. So with this case, the heel rises and then move up 1/2 centimeter and try again and measure to the nearest millimeter.